good morning in the US, and good whatever it is, wherever you are. But welcome to this session this evening. This evening, we are looking at COVID-19 vaccine and cancer. The reason why we are looking at COVID-19 vaccine and cancer is because we've had a few concerns about our cancer patients. What does COVID vaccine mean for them? Is there a good uptake of the COVID vaccine among the cancer patients? It has been discussed in various forums, even in the cancer task force that Deborah talked about. So we thought it would be good to have this session today so that we kind of understand what's going on in Kenya. We'll hear from Dr. Andrew about that, and also at a global level, Dr. Deborah will be telling us what's going on. So we really want to discuss the uptake of the vaccine among cancer patients and other factors affecting the decision-making process. If you're a Kenyan, you know the number of WhatsApp messages that come to you every day on what the vaccine does to you. People tell me I'll be dead in 2 years' time because I took the vaccine. So I've done 6 months with the vaccine, so I don't know if I'll be dead in another 1.5 years. But it says that some of the things would really like to be demystified. And then also just look at the global data on COVID vaccine. I would like to ask that if you're not speaking, you mute your microphone. If it's possible, if you can put your video on, it would be good to see who you are so that we have an interactive warm session. If you have anything that you want to add to the discussion, you can put in the chat. I think we have a Q&A. Do you have a Q&A? You can actually put even your questions in the chat.
In the chat.
The chat. Yeah. Later on, you can also raise your hand at the bottom, on the right-hand side. There's a reaction space where you can put your hand up and ask questions. So we'll be starting in a short while on the session, and I just want to say thank you very much to the two speakers who have agreed to give us a session on this topic, and also thank you to Mishka and the Kenco team for facilitating these ECHO sessions. I think they're very interesting and they bring us all together every now and then. So our first speaker is going to be Dr. Andrew Odhiambo. Dr. Odhiambo is a consultant physician and medical oncologist. He's the head of the unit in medical oncology and lecturer at University of Nairobi, Kenya. I know him as one of the young, smart doctors in Kenya. That's how I usually talk about him. He's one of those innovative young doctors in our country. He's, like I said, a consultant physician, medical oncologist, and the head of the medical oncology and lecturer in internal medicine at the University of Nairobi. He holds a master's degree in internal medicine from the University of Nairobi and did his fellowship in medical oncology in the UK and was certified by the Federation of Royal College of Physicians of the United Kingdom, and also as well as the Association for Cancer Physicians and the European Society for Medical Oncology. Quite a very rich background. He's also a fellow of the Royal College of Physicians of Edinburgh, as well as the East Central and Southern Africa College of Physicians. Like I said, he's a young doctor, but has accomplished so much in this short time. He is also the outgoing secretary and former treasurer of Kenya Society of Hematology and Oncology, and a member of Kenya Association of Physicians and others as well, including ESMO, AOTIC, and others. And he serves as an expert advisor for local and international bodies, that is Ministry of Health, Kenya Cancer Prevention Technical Working Team, ASCO, and NCCA, and National Cancer Treatment Guidelines Committees. He has also published in several articles, both local and international, in peer-reviewed articles, has been awarded the prestigious Business Daily at Africa Top 40 Under 40 Men in the year 2017. He's passionate about cancer, education and awareness, and especially through digital platforms. So his key areas of subspecialization and interest include colon cancer, stomach cancer, breast cancer, pancreatic, liver, and bile duct cancer. Dr. Andrew, those bile, liver, pancreatic cancers are usually very tough to deal with. Good luck. So, yeah, so those are mostly where his specialization lies. And then he's also has an interest in lymphomas as well, and immunotherapy and targeted therapy for some type of cancer. So, Daktari, karibu sana, welcome. Karibu means welcome, Deborah, in Kiswahili. And those who don't speak Kiswahili, karibu means welcome. Welcome to this session, and we are ready to listen to you.
Thank you very much, ZP. I hope I can be heard clearly.
Yes, loud and clear, yeah.
Let me just start sharing my... I just want to share my...
Christine is allowed. Have you allowed to share the screen?
Yes, he can share the screen. It's possible.
I think he's probably trying to rejoin. Right, he must be having some technical problem. Okay, he's back. Andrew is back.
Sorry, I fell off. Very sorry. Let me.
No problem.
Are you able to see my screen fully?
Hi. Yes. I'm okay.
Hello, VP, can you
If
see
you're
my
not the speaker,
screen?
mute your microphone. You can see your screen, but it's not on slideshow, but we can still see it.
Okay, just let me put it on slideshow.
We could still see it the other way, so it's okay even if you can just do the other way. That's okay.
And
we
now,
can still see it. We can see it. It's okay.
Oh, you can see it, yeah? Okay. So I think I'll just take about. You can be able to see it clearly. Hello, CP.
On my end, it's very clear. I don't know. I'm sure it's clear for everybody. Yeah, it's clear.
Is it on slideshow mode or it's full screen?
It's not full screen, but it's okay. We can actually see everything.
Okay, so I'm just going to take the next maybe 10 minutes or so to talk about my experience with the COVID-19 vaccines in the patients with cancer and give you some real life testimonies patients have shared with me and some cases that we have taken care of. I know Dr. Deborah will cover the more didactic issues, but some things might be a bit repetitive. So I have no disclosures. So this is just to remind us of the current numbers as at 6th of October. There are 236 million cases of COVID-19 worldwide, 45 million in the US, 8.4 in Africa, and just over 250,000 in Kenya. And this row here shows you the deaths in each area. In Kenya, we've surpassed the 5,000.
Doctor, your slides are not moving. Your slides are not. Are they moving?
They're not moving.
No, we are still on slide one.
Okay.
The introduction.
Let me just hold on. Let me try this again. And now, is it moving?
Yes, perfect.
Perfect. So I was on this slide for the numbers. So just to recap, there are about 236 million cases of COVID-19 worldwide, with 45 million in the US, 8.4 in the whole of Africa, and just over 250,000 in Kenya. In Kenya, we have surpassed the 5,000 death toll mark. In Africa, it's just slightly over 200,000. In the whole of US, there are about 723,000 deaths, and worldwide, we stand at 4.8 million. If you look at the people who are fully vaccinated, meaning they've received either 2 doses of the 2-dose vaccines or 1 dose of the J&J, there are about 2.71 billion, which is 34% of the world's population. In the US, they've vaccinated 186 million people successfully, and that's about 56.4%. in Africa, we are doing quite badly with only 62.7 million fully vaccinated. That's 4.5% of Africa's entire population. And in Kenya, we've only fully vaccinated 1.7% of the entire population at 947,000. So when VP asked me to give this talk, which was about 28 days ago, I decided to just do a random, very brief survey of the patients I see in my clinic. And since that day, I've seen about 134 patients in the outpatient clinic. Most of them are over 50 years with solid cancers. And the simple question I ask them is, have they been vaccinated? So 22 of them, which is 16% of this population, had received both doses. 81 had received at least one dose. And the most common dose here was AstraZeneca because it's what we got first. But 41, which is about 30% of them, are unvaccinated. Most of them, as I've said, have received AZ. But when I asked them if they had a choice, they opted for, could I have Pfizer? Could I have Moderna? And this is obviously because of the higher percentage efficacies that these vaccines have been shown to have, especially in preventing the mild disease. So when I asked them randomly, what are the main reasons for not getting vaccinated, in those who were not vaccinated, most of them were actually waiting to ask the doctor for permission to get the vaccine, because whenever they would present to the vaccination sites and they were asked if they have any comorbidities, and when they say that they have cancer, they were told, no, go and get permission from your doctor or go and get a note. Some of them just thought to themselves that, having cancer is a contraindication for getting the vaccine. So most of them really relied on permission from the doctor. Many of them would call me, can I get the vaccine? They would send you a WhatsApp or a message asking for permission to get the vaccine. Another big chunk of them were fear of the side effects, especially, with all the hype in the media. If even one person gets a clot, I used to tell my patients that COVID-19 gives you a 16-fold increase in the possibility of getting a clot, which is many hundred times more than the vaccine could give you a clot. But because they would see this on social media and they would really be scared, they would Google a lot of the side effects and be scared. They would see the experience of others, falling sick, getting headaches, getting fevers, being unable to go to work. And they would imagine to themselves, if a normal person is having side effects, what about me, who is having cancer, who is having chemotherapy? What's going to happen to me? Some of them told me that they think the vaccine would make the cancer to mutate, sort of lack of a better word, and even spread further. Some of them thought that the cancer or the treatment they are receiving is not compatible with the vaccine, and they really wondered whether it will affect their treatment, whether the chemotherapy would affect the efficacy of the vaccine. A few told me they really wanted to get vaccinated, but in the rural areas, the queues are excessively long. The level 2 and 3 hospitals would advertise that we are vaccinating. They would only come with 300 vaccines, and the line has 2,000 people. So they would come and go for a whole week, and then ended up giving up and not going. And some of them told me, we are waiting for Moderna, we are waiting for Johnson & Johnson, we are waiting for Pfizer. We don't want AstraZeneca because AstraZeneca has this and that types of problems. So the questions we ask ourselves every day, and I think this will be covered extensively in the didactic session, is why do the cancer patients need the vaccine? Who needs it more than the other? When is the best time to have it? Which one is the best one to have for the cancer patients? What about the booster? And for those who are opting out or refusing or delaying the vaccine, what are the reasons? And I think if we can be able to answer all these questions, then we would be in a better place to inform our patients on the right thing to do. So as far as who needs it, well, from the earlier data, it's very clear that cancer patients who get COVID have a poor outcome. And there's a lot of studies coming from China and many of the hard-hit countries that got it fast, so that many cancer patients had a higher chance of getting to the ICU and had a higher chance of death. Even surgery was more risky. And these particular risk groups, the male, the elderly, those with lung cancer, those with metastatic disease, and hematolymphoid cancers were identified as the high-risk groups. So we really, the cancer patients will benefit from this vaccine. So who really needs it? And I know this again will be covered in the session that is coming later, but generally, apart from the exceptions, we recommend it for all cancer patients. There's issues to do with timing, especially with the type of treatment that they are getting it. But one thing that we should probably consider is, and I'll talk about this in the next slide, is actually the stage of the cancer and the expected lifespan of that particular patient. And also, let's not forget the caregivers. So for most patients, it's okay to have it, and there's usually recommendations for different types of treatment. Are you getting plain chemotherapy? Are you getting highly immunosuppressive chemotherapy? Are you getting a stem cell transplant? Are you using a lympho depleting kind of treatment, rituximab, BTK inhibitors, and so on? So the types of treatment even matter a lot. And I know this will be covered later, but just I'd probably want to zero in on this continuum of oncology care, and probably we should be putting a lot of emphasis in vaccinating people who are in the earlier course of illness. Somebody who is approaching, end of life or is really onto end of life care and has a little time to go. I wonder what would be the benefit in giving that person a vaccine, and I think this will form a nice topic for discussion in the Q&A session. So the next one is, so which one? And I know this will also be covered. So far in Kenya, we've got the AstraZeneca, we have Moderna. I know the Pfizer syringes are now in. I don't know whether we had the real Sputnik or it was a fake one, but we also have received the Janssen or Johnson & Johnson vaccine. I'm not aware whether the China one or the Novavax are in Kenya, but at least the ones that I've ticked, I know that we have them. And it would be nice to throw this question to the rest of the panelists about which vaccine would be better for which patient. Does it matter, or can they all get the same vaccine? We have seen articles in the New England about the vaccine-associated thrombotic events or thrombocytopenia. I actually have one case, a gentleman I managed for metastatic colorectal cancer, who 2 weeks after receiving his first dose of the AZ vaccine developed thrombocytopenia that we could not explain. We never managed to test him for the antiplatelet factor 4 to confirm whether it was really a vaccine induced, but he suffered quite severe thrombocytopenia that did not respond to even transfusions. We would transfuse and it would keep going down, would give him L-thrombopag and it would still go down. And he ended up succumbing actually to COVID pneumonia itself. And it really got me thinking whether that was really an effect of the vaccine or it was just a bad luck once off. So I'm throwing this question out to the panelists so that we can discuss it. Let's see. Sorry, the slides are moving very quickly. I hope you can still hear me. So I think also for who gets a booster, I think this will also be covered in the didactic session, but my patients are already asking me. In fact, just this afternoon, I saw one of my patients who is a UN employee, and through their companies, they were able to get Pfizer in locally even before it officially got here, and now they are beginning to vaccinate them on their third dose, which is the booster. So she asked me, can I get the booster do I really need it? Is it for cancer patients? Can I not get it? Many of my friends who are getting the booster are having a lot of arm pain. They're not coming to work. They're getting tired. So I guess we'll also discuss that. And maybe the bigger question is for those who are opting out, why are they opting out? Why are they opting out? As I've said before, many of them were asking for permission. Fear of toxicity is very real. Access issues, sometimes there's even nowhere to get it, but I know with more dissemination and rolling out of the vaccine, mass vaccination drives, going to churches, going to schools will improve access. A lot of misinformation and stigma is facing many. I had a patient who told me he fears that he will get a permanent erectile dysfunction, and for those reasons he is not willing to get vaccinated. And he has researched that AstraZeneca vaccine will make him impotent, and therefore he does not want to get the vaccine. So there's still a lot of misinformation. Social media and the internet has really changed how some of the patients think and what they are prioritizing. So I think I'll end it there. I think my 10 minutes are over. But just from my small survey, I think majority of at least the patients I'm seeing who are seeking treatment in private centers in Nairobi have at least received one dose. That's about 60% of them, which is not bad. I would suspect that in the rural setting or those taking care in the public facilities, probably the uptake is much less due to access issues. Fear of toxicity is still a big reason, misinformation, rumors, and just sheer lack of information. Patients do not have even a digital platform where they can go and check and see whether the vaccine is safe for them, something that they can relate to, something that Ministry of Health probably can put more effort on to avail our cancer patients with more information. That's just a picture of me receiving my first dose of AstraZeneca vaccine in March. I always tell my patients that I have been vaccinated, both the first and the second dose. I had some effects, but I did not die, and I was working throughout the time. So thanks for your attention. I think I'd like to end it there. Thank you.
Well, thank you very much, Dr. Ujambo. That was really very interesting. I'm actually impressed that when we asked you to speak, you went and did a survey. So we have benefited from you, but you have also benefited from doing a survey. You can actually write a paper now. I think that's very interesting. Those points you brought out about, the patients asking which vaccine, when, what are the side effects, and I'm sure we'll have a lot of questions during the discussion. I just want to point out that I read in media, is it 2 days ago, one of our governors, I won't mention what, said that the vaccine has upped his sex drive. And so I'm surprised somebody else was saying it will cost, I don't know if you saw that, Bender. I don't know if it was fake news, but it was the news. So I'm just thinking, okay, here's somebody saying it helped him, and your patient is saying it might not help him. But we'll discuss those things at the end of when you're having the discussions. So thank you for those who are still joining us. And our second speaker is Dr. Deborah. I will not try to pronounce her second name. I think you can see it on the screen. It sounds more like an African name, but a very difficult name to pronounce. So Dr. Deborah joined the faculty of the American University of Beirut Medical Center in 2012 as a medical oncologist, and she is the Associate Professor of Clinical Medicine in that university. She has a special interest in genitourinary and gastrointestinal oncology, and she has completed her advanced specialty training in medical oncology at Guy's and St. Thomas National Health, I think so, I don't know, NHS Foundation Trust, London, UK, and was awarded a postgraduate diploma in oncology from the Institute of Cancer Research, University of London in 2011. Dr. Mukherjee, Deborah leads the Cancer in Conflict work stream of the Research for Cancer in Conflict collaboration at the University of Beirut, and she is also a member of the Global Cancer and COVID-19 Task Force investigating the impact of COVID on patients with cancer, focusing on lower resource settings. Thank you very much, Dr. Doctor. I keep on saying Dr. I'm sure you watched Kenyan. You watch old movies. I don't know if you watched a movie they used to sing Daktari. It used to start like that. The post-colonial movies, doctors in this country are called Daktari. It's a very common terminology. So when I say Daktari, just understand, I'm assuming that you're also Kenyan in many ways. So thank you very much for making time to join us. When we asked you, you were very willing to share your experiences, and you're welcome to share your experiences. Thank you.
Thank you very much. It's really a pleasure to be here with you this evening. I'm just going to share my slides. So as Dr. Zippi mentioned, we're working together in a global cancer and COVID task force, which is an academic collaboration that everyone is really welcome to join. And it's certainly something that we've really enjoyed throughout the pandemic, meeting virtually, and hopefully we'll be meeting in person soon. And I'd also like to acknowledge Dr. Laudi, who's I think with us in the meeting today, who's my research fellow, and she's also been helping with a lot of the ongoing work that we are doing, investigating the longitudinal effects of COVID-19 vaccines in our patients with cancer, and has been writing some reviews and helped me with the slides today. So let's see if I can move the slides. Here we are. So this is the collaborations that I mentioned. We have a website. We're also linked up with the UICC and King's College London, and now eCancer. So really would welcome everyone to get involved, and the more people that we get involved globally. As Dr. Andrew mentioned, we need valuable sources of information for our patients, and not just from high-income countries. So I think the more of us that can get together and do surveys, gather data, the stronger we'll be able to give recommendations to our patients. So we've already had a fantastic introduction by Dr. Andrew. I don't think we can do any better than that. Vaccine development has become a real global priority since the beginning of the pandemic. And as Dr. Andrew mentioned, patients with cancer have a higher risk of both morbidity and mortality compared to the general population. Some of this is related to age, and we know that age is the most significant risk factor. But in a systematic review and meta-analysis, around over a quarter of hospitalized patients with cancer who had COVID-19 actually died. So we know that this is a very important issue, protecting our patients and how best to do that. Vaccine development, we've heard mentioned that we have multiple vaccines which were rushed to development. Some are based on mRNA vaccines, but mainly we're basing our vaccines on this S-spike protein mediating viral attachment. So this is really the target of all our vaccination strategies. And currently this is a slide showing that more than 104 vaccines are being tested, large phase 3 trials. And one of the major problems is that unfortunately patients with ongoing malignancy and on anti-cancer treatment were in general excluded from these phase 3 trials. But we have many different types of vaccines which are on their way to development. Many have received full approval and are available in various countries around the world. So in Lebanon, we have had access to the Pfizer vaccine, the AstraZeneca vaccine. In other parts of the world, certainly my colleagues who are in the UAE, in Dubai and Abu Dhabi, they had a huge study using the Chinese vaccine, the Sinovac. But unfortunately, they had limited responses in a lot of their patients and then revaccinated most of the population with Pfizer. So these data have not really been published. And that's one of the issues, is the issue of data poverty and really not knowing the whole picture with these vaccine efficacy results. And I think that's where some of this mistrust of the public comes from. So as we mentioned, patients with cancer on active treatment were excluded from the initial vaccine studies, although we are having some data coming on. Safety and efficacy data are coming through, but mostly from patients in high income settings. And that's why it's really important that we get together and we work together in some of these studies, monitoring our patients with different vaccines and in different settings. Nevertheless, even before we had solid data, the professional societies were all recommending vaccination in patients on active treatment because of this observation that patients with cancer have a higher morbidity and mortality related to infection. So several studies have been looking at the vaccination immune response. Monitoring immune response has been quite difficult. We really don't know quite the best way of doing that. An easy way is to look at anti-spike IgG levels, Some studies have looked at neutralizing antibodies, and some studies have looked at T-cell responses, although these are quite expensive tests to do. So looking at seroconversion, and this is looking at anti-spike IgG levels, with solid organ tumours, the rates of seroconversion range from 86 to 100% in different studies. But in hematologic malignancies, and particularly patients who are on anti-CD20 therapies, much lower seroconversion rates, which makes sense because these patients are not creating good levels of antibodies. We conducted a study in Beirut in quite a limited resource setting, found that seroconversion rates were around 83% in a cohort of patients with both solid organ and hematologic malignancies, and that was recently published in Cancer, in eCancer, and we have that study ongoing because we really don't know how long this immunity lasts, and we need to look at breakthrough infections. So there's lots of data we still need. The anti-spike IgG levels have correlated with clinically relevant viral inhibition, but we really don't quite know what levels are good and how long these high levels will last. We need longitudinal studies, and we're currently now collecting data from patients both initially and after 6 months, then after 12 months. So these data will be coming along. T-cell responses, we do have some really limited data, and we saw some more presented at the last ESMO meeting. So these are improved in patients both with solid and hematologic malignancies, and there does seem to be a correlation between anti-spike IgG levels and the anti-tumor T-cell response, sorry, antiviral T-cell responses. And there are actually patients who are on anti-CD20 monoclonal antibodies who will mount an T-cell response. So this is reassuring to our patients when we test their antibodies and they're negative. The majority would mount a T-cell response. So around the moment, around half of patients, or half to a quarter of patients who are antibody negative will still have a T-cell response. And there's also been some really interesting data about the how long that lasts. So this is when we get to the idea of booster vaccine doses. And it's particularly interesting that it seems to be age as a major factor, which has been correlated with a drop-off of these anti-spike antibodies. So patients who are elderly and on active cancer treatment should really, really be prioritised for booster doses. So the effect of treatment, we mentioned cytotoxic chemotherapy, particularly anti-CD20 monoclonal antibodies have very, very poor antibody responses. And again, anti-CD38. So all of these treatments for hematologic malignancies have a significant effect on the humoral response to vaccines. CAR T-cell treatment, I'm not sure how much of that has been used. It's not really being used in Lebanon at the moment. Again, associated with significantly decreased immune responses to vaccination. But so far, the immune checkpoint inhibitors do not appear to have a negative effect on humoral immunity responses to vaccination. So we can safely deliver COVID-19 vaccines to patients on immune checkpoint inhibitors. There's really been no evidence that there's extra side effects, which is what we were quite concerned about at the beginning. So at ESMO, I mentioned we had some really interesting data. These were 2 studies presented at the presidential sessions. The CAPTURE trial is a large Dutch longitudinal study, really the largest cohort of patients so far. They found, again, as we've been noticing from smaller studies, that the immune responses are really about as good in patients with solid organ malignancies as in the general population, but significantly suppressed in patients with hematologic malignancies. The VOICE trial is really interesting translational work from the Royal Marsden. Again, they saw T-cell responses seen in half of serologic non-responders or suboptimal responders. And these data are going to be followed up longitudinally to see how long these responses last. And patients who have vaccinations are being also monitored for breakthrough infections, which is really, really important data that we need to gather. Because we are talking about, in some ways, vaccine hesitancy and concerns about toxicity, this big cohort of the adverse events in the Dutch study, they looked at death from any cause, they looked at adverse events of special interest, including thrombotic events, thromboembolic events, and they really were very, very rare, and some of these may have been related to the anti-cancer treatment. Also, patients who are taking anti-cancer treatment, and I think Andrew mentioned this is one of the key questions, we really don't quite know when to vaccinate them. So there are some guidelines which are really not very evidence-based, but delaying until ANC recovery in patients on cycles of cytotoxic treatment, and ideally before we start anti-CD20 therapy or cellular therapy, or at least 3 months afterwards. So these are the sort of NCCN guidelines at the moment, which have been published, but we really don't have really clear evidence-based or data-driven guidelines to discuss patients when vaccination should happen. And these are the timing and third dose recommendations from various authorities. So the FDA and CDC have recommended a third dose for all patients with moderate to severe immunodeficiency. And actually in the US, they're giving a third dose to all patients above 50. And in the UK, they're recommending a third dose as part of the primary vaccination series. There are some data, these data are extrapolated from patients with organ transplant, and we really have very few data about patients with anti-cancer therapy. So this is something which we really need to monitor. And unfortunately, it is very resource driven. So where we are in Lebanon, we don't actually have the resources at the moment to start offering booster doses. So I've just had the information that we have around 50% of the population, eligible population, registered with the Ministry of Health to have vaccination, but the proportion of patients who completed their vaccination is less than 30%. So of 2 doses, so around 26% of the population have had 2 doses. The eligible population in Lebanon have had 2 doses. So when we're dealing with low levels of vaccination, it really becomes an issue as to who should we prioritise to offer a third dose to. So lots of questions requiring further explanation. Response duration, we really don't know. We don't know who should have a booster. Monitoring of antibody levels, is it helpful or is it not particularly helpful in patients with cancer? Does it correlate with protection from breakthrough infections? We're not quite sure. This is something which we really urge everyone to start prospectively consenting their patients and collecting their data in all parts of the world, because only through data collection is when we're going to really have answers to these questions. And prevention priorities for low resource settings. We know that vaccination rates are much lower. We've seen Dr. Andrew's slide about vaccination rates in Kenya. We have a widening vaccination gap. So in the US, where a large proportion of patients are vaccinated and now getting third doses, we are in other countries in the world where very little vaccination is happening. And we also have this information spread, disinformation spread, and we have problems with patients having lack of access to vaccines and lack of access to the ways to stay safe from COVID-19 infection. If the patients who are vulnerable and their caregivers are not being vaccinated, then this is a huge problem which is just not going to go away. There's some really, really interesting data about vaccine efficacy and iron deficiency anemia. So this is really from models, and this is a really interesting paper in the Lancet Hematology that we read, looking at exploring the hypothesis that there may be suboptimal vaccine responses in patients with iron deficiency, and this is something really important for different parts of the world and lower resource settings. So this is why, another reason why we need data from different areas. Maintaining strict precautions in patients with cancer against COVID-19, even post-vaccination, is really important. I think that's the key message, that not everyone is protected, particularly in communities where vaccination rates are low. So in summary, and there's lots to discuss, looking forward to discussing with you all, vaccines are safe and generally effective in patients with cancer. Some patients, particularly with hematologic malignancies treated with anti-CD20 treatments, have decreased humoral immune responses. Booster doses are likely to be effective, resource permitting, and it really should be the elderly and patients on active immunosuppressive treatment who should be prioritised. There are many, many questions to be addressed. We do have lots of longitudinal studies ongoing, but most of these are in high-income countries. So we really need to join together to get some of these data from patients in different parts of the world. Vaccine access issues and barriers to uptake, even if the vaccine is available. So this vaccine hesitancy question is really important. And I love the fact that you started collecting data in your survey, and we do have, in our patients, we have an IRB approved survey that's ongoing at the moment. So we'd love to link up and perhaps something we can do together in different centres to look at the reasons why patients are being offered vaccines and are not taking them up. And prevention of infection, maintaining those precautions in vulnerable groups, even after vaccination, should remain our key message. That's it. Thank you so much. Looking forward to the discussion.
Thank you very much, Dr. Deborah. Thank you so much for that information. I think one reassuring thing is that vaccines are relatively safe in cancer patients. And for us, we are still struggling with the first doses, second doses. So I hope we'll be able to get even the booster doses for our patients. It's a bit of a challenge, the inequity in terms of access to vaccines. But thank you so much for that data that is that you've shared, especially based on a lot of research. That's very interesting. Thank you. And so I just want to invite questions. Dr. Andrew Dembo is still with us. Thank you, both of you, for wonderful sessions. I have not seen people type, but I think we can raise our hands up and ask any questions. I can start by asking, because one of the questions I get a lot is that the mixing of the different types of vaccines. I mean, if you get AstraZeneca this time, the next time you should get Johnson & Johnson or something like that. Still not very clear how safe that is. I think in the West, is it true that in the Western countries, they have already started doing that? We might not have the luxury of having to mix the vaccines, but just maybe from both of you, what do you think in terms of mixing vaccines? Should the booster vaccine, the third one that a cancer patient is getting, be a different type of vaccine from the first and second one?
A really good question. And there are some data which suggest that mixing vaccines could actually give a more potent immune response. But unfortunately, we don't have a lot of data, particularly in patients with cancer. And the question now is really access. So I think we're just saying, you know, whatever you're offered, take it. And really the safety data are there. The safety data are there. We don't see excess morbidity in patients who are on anti-cancer treatment. I think I'd recommend whatever is available.
Thank you. Dr. Andrew, do you want to say anything to that?
I think I don't have experience with patients who have mixed vaccines, but I would agree with Deborah. Whatever you have in front of you, just take it. Obviously, Pfizer CEO would not be happy to hear that AZ is mixing with them, but I guess if it comes down to increasing the percentage of fully vaccinated individuals, then just get whatever you've got.
Thank you. Audience, participants, please, any questions, any concerns, any additions, subtractions as well?
So I think we've got one question about breakthrough infections.
It has just come in, okay. Yeah, go ahead.
So the question was about, do vaccines prevent infection or prevent one from getting severe symptoms, hospitalization and death more likely? So absolutely, breakthrough infections are possible even in the fully vaccinated populations. And now we've started seeing healthcare workers having breakthrough COVID infections. But what we do see is a significant decrease in the rate of hospitalization and severity of infection and death. So this should remain our key message to all, that even if you've been vaccinated, particularly if you have cancer and on anti-cancer treatment, you are not 100% protected. So for the patients, the caregivers, the healthcare workers, we have to really remain vigilant, because even a mild infection to a patient who is immune compromised may be more serious. So we're collecting those data about breakthrough infections. So far, we have had some. We haven't had any patients who have died. We have had a few hospitalizations, but this should remain our message.
Thank you very much. That's very interesting, and thank you for that answer. There's somebody who's saying that these vaccines take only 6 months and then they're not protective anymore. So is there really a need to be vaccinated? What they're asking. I don't know if it's true that after 6 months the vaccine is no longer valid in your body or not. So maybe that's what they want to find out.
That's what we're collecting data about at the moment. So in Lebanon, we do not have access to boosters. So we're now getting up to the sort of 6-month mark. And we're definitely seeing the anti-spike IgG levels decrease in patients. But we don't, it really is very variable. So age is a big factor. Treatment is probably going to be a big factor as well. But these are data which we really are not sure from any of the series. So this is why we really need to keep collecting those data. And the study that we're doing at the moment will collect samples at 6 months and then at 12 months. And at the moment, it doesn't look like any of our patients will get boosters. So it will be a really interesting cohort.
Yeah, thank you. Yeah, that's actually, it takes time to really get solid, concrete data on vaccines. So these vaccines are a new initiative. So it will take time for us to be able to prove most of these things. Somebody is saying that they have a relative who has developed symptoms for COVID-19 like symptoms and is quite sick. Is it necessary for them to do? Should it have been necessary for them to do a COVID test before being vaccinated?
Before being vaccinated, probably no. But if someone has symptoms, even if they've been vaccinated, we recommend testing because of these breakthrough infections. So I developed a sore throat and a cold this morning. So luckily I was able to access a rapid test, which I didn't. So yeah, absolutely. We should still be testing symptomatic patients, carers, members of the public. And this issue is not going to go away. I mean, this is such an important problem.
Okay. Thank you. And again, just somebody has asked a question that is similar. Well, actually, we responded to it in many ways. Where it says, they're saying that Shem is saying that vaccines take about 10 years to be approved, developed and approved, scientifically, and and how quickly did we discover this COVID-19 vaccine? That we are giving them to human beings.
I think this is some of the concerns that people are saying that, has it been rushed? Are there toxicities that we don't know about in the future? And this is part of the fear that many people have. But I think that we have to remember that this vaccine technology has not sprung out of nothing. This is built on decades of research. We have a new flu vaccine every single year, which is developed on the back of the last year's samples. I don't think that we are going from zero in terms of the technology or in terms of the testing. These are platforms which are well tested in other coronavirus diseases. This just happens to be something which was completely novel and more severe than anyone anticipated. But these vaccine technologies have been around for a long time. But the ongoing safety data is pretty reassuring.
Yeah. Yes, thank you. And I listened a lot to CNN when vaccines were being launched, and that's what they kept on saying, that the technology has improved, so things can be processed faster. So let's hope that all that conspiracy of we'll be dead in the next 2 years is not going to happen, that we'll still be alive in the next 2 years, even after getting the vaccine. So thank you. There's no other question, but maybe a parting shot from both of you, from each of you, before I hand over to Christine. Andrew, you want to go first? I'm sure you want to go back to your clinic.
Yeah, so I think, first of all, I've enjoyed the session. I'd probably like to join the next one, and maybe thank you to the organizers for giving me this platform to share. I think this has shown me that actually we need to formally collect data on our patients and see on a larger scale why they are not taking the vaccine and what are the issues on the ground. But generally, as has been said, I think they are safe for all cancer patients, but it's important to get guidance from your oncologist or your doctor as to when is the correct timing and whether you are a candidate for the vaccine. I think that's all I have to say, and I've really enjoyed the session. Thank you.
Thank you. Thank you so much, Dr. Thank you for those words of wisdom. Deborah?
Thank you so much for inviting us to be part of this session. It's been wonderful. And I really like to echo Dr. Andrew's sentiments that we really need to work together to get new data. And I loved your idea about having better channels of communication for patients, because unless we have really good channels of communication for patients in their own language, culturally appropriate, then they're going to look at the things on YouTube and WhatsApp and Facebook, which are conspiracy theories. So yeah, I think this is something as a community that we can work better to provide good data and better communication for our patients.
Thank you. Thank you very much, Deborah. And now that you know Andrew, you have his email, you can always collaborate and include him in the task force. He has a lot to share. So thank you very much. Thank you to both of you for this session, and all the participants, thank you very much. So I'll hand over to, we have the conveners of these sessions. Usually it's Kenya Network of Cancer Organization, overseen by the NHI. Mishka, are you NHI, NIH? What are you? NCI.
NCI, yes.
All these things confuse people. And Mishka is pretty much a Kenyan. She lived here for almost 12, 13 years. So she's picked up all our habits. She understands when we say Daktari. So thank you very much. I'll hand over to Christine and Mishka. Thank you very much, everybody.
Okay, so thank you so much, Dr. Zipporah, for the great moderation. Thank you so much, Dr. Andrew and Dr. Deborah, for the great insights. I believe we've all enjoyed the session. We've had some of our questions answered, and I believe we'll continue the discussions at Basecamp. So for me, just one announcement. Our next session will be on October 21st, and we'll continue with the COVID-19 session, but this time dealing with cancer and mental health during this pandemic season. So over to you, Mishka. I believe you have more comments about Basecamp and the slides and recordings. Thank you so much.
Yes, thank you, Christine. And I did see a question in the chat about sharing. I'm putting into the chat the link to Basecamp. We've been trying to use that platform more regularly as our mode of communication with this community. We will be posting the slides and recordings after this meeting to Basecamp and have a place there to store them. And we can add any one of you to the Basecamp if you're not already on it. So you can email me directly. I think everybody here has my email address, but I'll just stick it in the chat as well, including Deborah and Andrew. If you would like to join this community, we would welcome to have you on for future sessions as well. So thank you, everybody, for joining today. And thank you very much, Zippy, for a fantastic facilitation and the great session. So with that, back to you, Zippy, to close this up.
Thank you. I don't know if we have a chair. I don't know if she wants to say anything. Is she, Amaka? Is she there? Amaka?
Yes, I'm here. Hello.
Maybe you just want to give you the final word.
Oh, wow. I think you've done a great job. This has been a really, really interesting session. I mean, there have been many questions about how to present these vaccines and encouraging our patients to take them up. So this has really shed a lot of light, and it was really a great session. Thank you all to everyone who has joined and stayed till the top of the hour, and most especially to both our presenters, Deborah and Dr. Mujahid. Thank you so much. And we look forward to continuing the discussion next week, where we look at it from the point of view of the healthcare workers. Thank you. Over to you, Zippy.
Thank you, Dr. Maka. Dr. Maka is an oncologist also. She's also our chair. So thank you very much, everybody. Thank you so much. Deborah and Andrew joined us whenever you can. We have very interesting discussions here. And we are doing also some few things like, I think, looking at some survivorship research. And Miriam was supposed to join us today, but she was not able to join us, Miriam Mutebi, but send apologies. But thank you very much, everybody. Do have a good evening and see you in our next session on mental health and COVID-19. Kwaheri means bye-bye in Kiswahili.
Bye.
Bye.
Bye, everybody.
Bye-bye.
Thank you.
Bye.
Thank you for joining. Bye.
Bye. Bye.